Welcome to the BioPharma Business Intelligence Unit, where symbolic integrity meets strategic clarity. At BBIU, we go beyond the headlines to decode the structural forces behind global biopharma, AI, and economic realignment. If you value precision, verification, and symbolic depth, this channel is for you. Subscribe now to access our weekly briefings, dossiers, and intelligence reports, and consider joining our institutional tier to unlock early warning systems, custom metrics, and exclusive strategic insight. You're not just listening, you're entering the future of epistemic intelligence. www.BioPharma Business Intelligence Unit.com.
Low-dose aspirin in PI3K-Altered Colorectal Cancer, from Observational Hints to Randomized Proof Executive Summary. The NEJM publication by Martling et al. 2025 delivers the first randomized evidence that low-dose aspirin, 160 mg per day for 3 years, reduces recurrence in localized colorectal cancer, CRC, patients harboring PI3 pathway alterations. While retrospective and observational studies had long hinted at an aspirin benefit in PI3K-mutated tumors, this Scandinavian double-blind, placebo-controlled trial provides prospective validation. Among 1,103 patients with somatic PI3K alterations, 37% of the tested cohort, aspirin halved recurrence risk. PI3A exon 9 20 spot mutations, 7.7% versus 14.1% recurrence, HR 0.49. Other PI3K pathway mutations, PI3CA non-hotspot, PI3R1, P10, 7.7% to 16.8% recurrence, HR 0.42. 3-year disease-free survival was consistently higher in aspirin-treated groups, though serious adverse events, notably bleeding, occurred more frequently, 16.8% versus 11.6%. The trial positions aspirin not as a population-wide chemopreventive, but as a precision adjuvant strategy anchored in tumor genomics. Its implications span clinical practice, drug repurposing economics, and health policy.
Structured BBIU analysis. In September 2025, a Scandinavian research consortium published in the New England Journal of Medicine what may be one of the most important clinical trials of the decade in oncology. The trial, known as ALASIA NCT264799, tested something that sounds deceptively simple: whether a daily low dose of aspirin could prevent colorectal cancer from coming back in patients whose tumors carried specific genetic mutations. For more than 120 years, aspirin has been the most common pill on the planet, used for headaches, fever, and cardiovascular prevention. But in cancer, the story has always been complex. Observational studies hinted that aspirin might reduce the risk of colon cancer. Retrospective analyses found that patients who took aspirin for heart disease seemed to develop fewer tumors, and that those who already had colorectal cancer sometimes lived longer. Yet, these were associations, correlation, not causation. Randomized proof was missing. The mutation, PI3CA and the PI3K pathway. At the heart of the Alaska trial lies the PI3K pathway, a central signaling cascade in the cell. The PI3K gene encodes the catalytic subunit P110A of PI3K, an enzyme that generates the lipid second messenger PIP2 in the cell membrane. PIP3 is not just a chemical detail. It acts as a docking site for proteins like AKT, which once activated drive the cell forward, making it grow, divide, survive stress, and override internal brakes. When PK3CA is mutated, most often in hotspot regions in exon 9 or 20, the pathway is stuck in the on position. This means cells generate PEP3 continuously, leading to perpetual AKT and mTOR activation. At the cell cycle level, this hyperactivation disables natural checkpoints. AKT blocks the inhibitors P21 and P27, freeing cyclin CDK complexes to phosphorylate RB, release E2F, and push the cell from G1 into S phase. Translation: the cancer cell keeps dividing even when it shouldn't. Roughly 10 to 20% of colorectal cancers carry PI3K mutations. They form a genetically defined subgroup, a molecular fingerprint that alters the biology of the disease.
The clinical trial, Alaska, NCT02644799. The Alaska trial, led by Anna Martling and colleagues, enrolled more than 1,000 patients across Sweden, Norway, Denmark, and Finland. All had localized stage 2-3 colorectal cancer. All had undergone radical surgery and, when indicated, chemotherapy. All had tumors genetically tested for somatic mutations in the PI3K pathway, PI3CA, PI3R1, P10. Patients were randomized to receive either 160 milligrams of aspirin daily or placebo for 3 years. The primary endpoint was time to recurrence, TTR, local recurrence, distant metastases, or death from the same cancer within 3 years. Secondary endpoints included disease-free survival, overall survival, and adverse events. The trial was meticulously designed. Eligibility criteria excluded patients with hereditary syndromes, Lynch, AFAP, inflammatory bowel disease, metastases, bleeding disorders, concurrent anticoagulant therapy, uncontrolled hypertension, significant liver or kidney disease, or conditions incompatible with aspirin. The aim was to isolate the effect of aspirin in a genetically defined and clinically stable cohort. The results: cutting recurrence in half. The outcome was striking. In patients with PI3K hotspot mutations, exon 920, the 3-year recurrence rate was 7.7% with aspirin versus 14.1% with placebo, HR 0.49. In patients with other PI3 pathway mutations, PI3K non-hotspot PI3R1 P10, recurrence was 7.7% versus 16.8 HR 0.42. Disease-free survival improved similarly, from 78 to 81% to nearly 89%. This was the first randomized confirmation that aspirin truly reduces recurrence in colorectal cancer, but only in genetically selected patients. Safety, however, was not trivial. Severe adverse events occurred in 16.8% of aspirin-treated patients versus 11.6% in placebo, mostly bleeding-related. Aspirin is cheap and effective, but not free of risk.
The precise biology remains under study, but the evidence converges on 2 interconnected effects. COX prostaglandin axis. Aspirin blocks cyclooxygenases COX-1X2, reducing prostaglandin E2, PGE2. PGE2 normally reinforces PI3K-KT signaling. By lowering PGE2, aspirin weakens the feedback loop that supercharges P3A-mutated tumors. Direct modulation of AKT-mTOR. Preclinical data suggest aspirin may reduce AKT and mTOR phosphorylation in PI3K mutant cells, partially restoring cell cycle breaks. Together, these actions blunt the hyperactive PI3 signaling, making it harder for cancer cells to cross the G1S checkpoint. In effect, aspirin narrows the genetic loophole exploited by PI3K-mutated tumors. The ELICA findings align with decades of epidemiologic signals. Nurses' Health Study and Health Professionals Follow-up Study. Long-term aspirin use reduced colorectal cancer risk, especially in COX-2 high tumors. Post-trial follow-ups of vascular aspirin studies, benefits emerged after 5 years, particularly in proximal colon cancer. CAP2 trial, Lynch syndrome, high-dose aspirin, 600 milligrams, reduced cancer incidence after a latency of 5 years. Aspirin trial, elderly, 70 years, aspirin showed no cancer prevention benefit and even early harm, highlighting the risk of bleeding and the limits of generalization. Taken together, these studies underline a crucial point. Aspirin is not a universal anti-drug. Its benefit depends on genetics, PI3K, tumor biology, COX-2, age, duration of use, and patient comorbidities. Symbolic and economic resonance. The implications go far beyond medicine. Clinical practice, PIK3CA genotyping may soon become standard in colorectal cancer management, not only for targeted therapy but to guide aspirin use. Economics, aspirin costs pennies a day. If validated globally, it could rival expensive biologics in reducing recurrence risk, challenging oncology's cost structures. Policy, health systems may face pressure to integrate molecular stratification into standard care, creating a new paradigm where old drugs are repurposed with genomic precision. Symbolism. Aspirin, the archetype of generic pharmacology, is reborn as a genomic therapy, bridging the past and the future of medicine. BBIU conclusion. The Alaska trial demonstrates a profound lesson. The future of oncology will not be defined solely by billion-dollar molecules, but also by the genomic resurrection of century-old drugs. Aspirin's benefit in PI3K-mutated colorectal cancer is scientifically consistent, economically disruptive, and symbolically powerful. It reminds us that precision medicine does not only mean new. It can mean reinterpreting the old through the lens of genomics and second messenger biology. In doing so, aspirin forces the field to reconcile 2 truths. Cancer can be stopped by expensive, futuristic biologics. Cancer can also be slowed by a tablet that costs less than a cup of coffee. This paradox between cost and precision, old and new, defines the symbolic frontier of oncology in 2025. Annex: The Origins and Risks of Aspirin. The story of aspirin begins long before laboratories and randomized trials. Ancient civilizations knew that the bark of the willow tree, salix, could ease pain and fever. Egyptian papyri, 1500 BC, and Hippocratic texts both record its use. The bitter taste of willow decoctions carried a hidden pharmacological truth: the presence of salicin, a natural precursor of salicylic acid. In 1763, Reverend Edward Stone, an English clergyman, formally presented to the Royal Society his observations that powdered willow bark relieved fevers. His method was empirical but systematic, and it represents one of the earliest examples of clinical experimentation in Europe. The 19th century turned folklore into chemistry. 1828, Johann Buchner in Munich isolated salicin. 1838, Raffaele Piria in Pisa converted salicin into salicylic acid. 1853, Charles Frederick Gerhardt synthesized acetylsalicylic acid, though he never commercialized it. The decisive step came in 1897 at Bayer's laboratories in Germany, when chemist Felix Hoffmann acetylated salicylic acid to create a more tolerable derivative, acetylsalicylic acid, trademarked as Aspirin, A for acetyl, spire from spirea, a salicin-rich plant. By 1899, aspirin was marketed in powder form, by 1915 in tablets. From then on, it became the most consumed medicine in the world, taken for headaches, fever, rheumatism, and later cardiovascular protection. This history is symbolic, from willow bark gathered by a reverend in rural England to a chemical transformation that shaped modern pharmacology. Aspirin embodies the continuity between empirical wisdom, experimental science, and industrial medicine. Yet history also carries a warning. The indiscriminate use of aspirin, so easily accessible and so widely consumed, has produced countless cases of gastrointestinal bleeding, peptic ulcers, and hemorrhagic strokes. What was once a universal household remedy is now recognized as a powerful drug whose benefits must always be weighed against significant risks. In 2025, aspirin re-enters oncology as a precision therapy for PI3K-mutated colorectal cancer, but its story reminds us that precision means restraint. Not every patient should take it, and in the wrong context, what once healed can also harm.